Okay, hello everyone, and welcome to BrainMap. This seminar series is co-sponsored by the P41-funded Center for Mesoscale Mapping, housed in the Martinos Center. It's my great pleasure to introduce our speaker today, Dr. Bragi Sveinsson. Dr. Sveinsson is an instructor at the Martinos Center for Biomedical Imaging at the Massachusetts General Hospital and Harvard Medical School. He earned his PhD in electrical engineering from Stanford University, where he worked with Professor Brian Hargreaves and Professor Gary Gold to develop methods for assessing cartilage microstructure for early detection of osteoarthritis and for imaging close to metallic implants. Upon completion of his studies at Stanford, he moved to the Martinos Center for a postdoc at the lab of Professor Matt Rosen. There he has investigated computational methods to improve MR imaging and analysis using AI and augmented reality technologies, as well as working on novel methods for brain imaging at low fields and peripheral nerve imaging at high fields. He is a junior fellow of the ISMRM and is supported by a K99 Pathway to Independence Award from the National Institute on Aging to investigate quantitative imaging of muscle tissue. I would just like to remind the audience to please address any question you have using the Q&A box or raise your hand. Dr. Sveinsson, thank you very much for coming here today. The virtual stage is all yours.
All right. Yeah, thank you so much for having me. I'm very excited to give this talk. I guess we already went over my background for the most part, so I'll just skip over this very quickly. But this is a picture of me, and I'm an instructor at the Martinos Center. I joined a few years ago as a postdoc in the low field MRI and hyperpolarized media laboratory headed by Matt Rosen. And before that, I was in the body magnetic resonance group at Stanford headed by Brian Hargreaves. And before then, I did my undergraduate degree in Iceland, and that's where I'm from in that picture down there. So in this talk, I'm going to talk about musculoskeletal imaging, perhaps a somewhat unusual topic for the seminar series. I wanted to spend a little bit of time just describing the problem and give a little bit of background. So musculoskeletal imaging generally involves imaging of tissues such as bone, cartilage, muscle, and so on. And in this talk, I'm going to focus mostly on cartilage. These types of tissues present somewhat unique challenges compared to, for example, brain imaging. Specifically, the relaxation times are short, meaning that you have weaker signal, so SNR is always a bit of a challenge. The diseases that we're interested in when looking at these tissues, where there's a range of them, but the one that I maybe kind of focus on most is osteoarthritis, or OA, as we sometimes just shorten it, which is a joint disease that affects the whole joint. And there isn't really a cure for this disease at this point, except for just joint replacement when the joint has become very damaged. Obviously, we would like to do better than that. So I'm going to describe some methods for doing that in this talk. So the role of imaging typically involves just a radiologist looking at the tissue and sort of inspecting how damaged it is. You can see this pretty well here in a healthy volunteer on the left and a osteoarthritis or OA patient on the right. So the radiologist assesses how damaged the tissue is and performs an assessment of some kind. But this usually happens at a fairly late stage in the disease. And ideally, we would like to perform imaging at an earlier stage where the process can be maybe reversed a little bit better. There have been some or several methodologies devised for assessing these images in what you might call quantitative, semi-quantitative assessments. I list some of them here, and they measure various things such as joint space narrowing, cartilage loss, lesions, and so on. But what ideally you would like is to get something that's maybe purely quantitative, where you get some kind of number, some numerical measurement with an absolute number that tells you something about the state of the tissue and whether there's pathology or not. And you can picture this as obtaining basically a a collection of quantitative measurements, one for each pixel, that generates a map like we see here to the right. And so ideally, you would get a map that gives you some kind of number like this, or a range of numbers, and that would help the radiologist in their assessment and maybe make it more sort of perhaps more automatic, more objective. And also it could help with telling us that something is wrong with the tissue even before it becomes visible in morphology. So what is it that these quantitative maps can tell us? Well, if we sort of zoom in on the cartilage tissue like we do here, the cartilage is composed of, well, mostly water, but it has collagen and glycosaminoglycans, which is shortened as GAG or GAG there. And what we would like to do is to get some kind of assessment of the state of this microstructure, whether there is some kind of breakdown taking place. And there is literature showing that you can correlate T2 measurements with the collagen matrix that is shown in the drawing. And diffusion measurements can give an indication of the state of the glycosaminoglycans. And now I'm going to talk a little bit about the imaging methodologies that are often used in musculoskeletal imaging. It's common to use what we call steady state imaging methods. These are SNR efficient methods that you can basically define as the magnetization having not fully relaxed before you hit it with your next radio frequency pulse. This results in more complicated signal behavior than you get with many other methods. So the modeling of the signal can become fairly complicated. After a number of repetition times, it settles in what we call steady state, and that gives a special tissue contrast. The most perhaps straightforward of these is what is called balanced steady state free precession, or balanced SSFP. That has a signal response that you can draw like a curve that I'm showing here. It gives a very strong and good signal. The drawback is that it is sensitive to off resonance. So I'm showing that on the x-axis here. And as many of you know, if you're sufficiently off resonance, you can actually get a zero signal like I'm showing with the arrows here. And this results in banding artifacts in your images, which you don't want, obviously. So to get rid of these banding artifacts, what we will often do is apply what's called spoiling. So if you look at a very basic schematic of a balanced SSFP pulse diagram at the bottom here, and just in the interest of space, I'm just going to draw everything on the same axis, whether it's RF pulses or signals or what have you. So if you look at a basic balanced SSFP signal here, what we want to do is eliminate the banding by eliminating any residual transverse magnetization that is at the end of the repetition time. And you can do this using, basically, there are two ways of doing this. One is called radio frequency spoiling, or RF spoiling. So there you apply incoherence to the phase of your radio frequency pulses. That makes them not contribute to later signals. And that gets rid of your banding artifact. The other way is to use what's called gradient spoiling. So there, instead of the incoherent phase, what you do is you apply a gradient, and that dephases the magnetization so that it doesn't give any net signal. This is used in methods such as that are called things such as FISP, and you have different acronyms depending on the vendor. So then you apply the signal there, as shown at the bottom, and then you spoil it with the gradient. It does create a stimulated echo in later repetition times after the gradient, and where basically your magnetization has been flipped by subsequent radio frequency pulses and then gets rephased by the subsequent gradients. And there are techniques that look at this signal instead of the primary one, and sometimes they're called just, well, PSIF is one acronym. That's just FISP in reverse. And then there's yet another methodology that collects both of these. That one is called double echoing steady state, or DES. And I'm going to talk about that quite a bit in this talk. So it collects both the signals before the gradient and after the gradient. I'm going to label those as S1 and S2. And we'll get back to those. And I should maybe add also that that the RF spoiled methods that I talked about before usually or always also use a gradient as well as the RF spoiling, even though I didn't show it. And these methods include acronyms, or they're called acronyms such as SPGR and FLASH. So that's the background. With that, I just wanted to go into various research projects that I've been involved with that try to improve our capacity of doing imaging, musculoskeletal imaging. Mostly, it involves these quantitative maps that I talked about, although not completely. And they can broadly be split into what I call signal modeling, where I look more at the MR physics, and then computational approaches that involve various computational methods. And just to, I'm just going to start with the first one here that I call T2 estimation in steady state. So going back to the double echo in steady state, or DES sequence that I talked about earlier, like I mentioned, it produces these two signals, S1 and S2, and oftentimes these are combined for SNR purposes into just one image. But would it be possible to, instead of combining them, looking at their relative contrasts, because they are different. The S1 signal typically has like a T2 over T1 contrast, while the later signal has a more T2 contrast and sometimes diffusion weighted contrast as well. So could we look at the amplitudes of these signals and estimate parameters such as T2? And this way, we could get both high quality anatomic data as well as quantitative maps from the same sequence, like is shown at the bottom right. And this has several benefits, including very easy co-registration with the anatomy and not having to run a separate quantitative scan and so on. This is non-trivial though, because the signal relationship is much more complicated than in the scans that you would typically use to estimate T2. You don't have the sort of simple T2 decay, the exponential decay. You have a more complicated relationship, and it's also not easy to separate the effects from various decay mechanisms. There have been ways to develop analytical models to describe this, and here is one that has been very useful, and it kind of assumes a sort of a spin-echo relationship between the two signals over two TRs. So it's quite useful, but it does not include the effects of spoiling or flip angle. So the question is whether we can maybe improve on this a little bit. And just to show that it can give errors in your estimation, here you can see basically our prediction is just shown with a horizontal black line at the top. And I varied the flip angle with the x-axis, and the green and the blue lines represent varying the spoiling. And you can see that you know, if your flip angle is small, for example, or your spoiling is big, then this can introduce errors. And just to make a long story short, we did show that you can create a kind of a correction factor to this relationship that takes into account both of these effects that I talked about before. So if this is just the same plot as I showed before, but if you look very closely now, you'll see that now you should see these dashed lines right up against the green and the blue plot. And this is this new model. So you can see that it captures these effects a lot better. And this, using this methodology, you have this analytical way of creating T2 maps from tests that we found quite useful. So that's it for the T2 estimation in steady state. And I'm just going to move on to what I call denoising steady state ADC measurements, and ADC here stands for apparent diffusion coefficient. So I talked about earlier how the spoiling changes or it affects the signal magnitude. And the reason really is because the spoiler gradient can act as a diffusion sensitizing gradient, similarly to what we're used to in just your standard diffusion weighted imaging. And you can use this to your advantage. So you can deliberately make the spoiler big and get diffusion weighting in your signal and try to use that to estimate diffusivity instead of using your maybe typical sort of EPI DWI scan. So you would run basically the sequence twice, like I'm showing here at the bottom, where one of them has large diffusion sensitivity with a big gradient. The other one has a smaller gradient that kind of functions sort of similarly to your B, B equal to 0 DWI scan. So this has benefits. One of them being, for example, that it doesn't suffer from distortion like we are used to seeing in EPI scans. And again, it allows for easy overlay with anatomical images. But it has drawbacks as well. And probably the biggest one is just that your sensitivity to diffusion isn't great, even with a big gradient. So you get pretty noisy estimates like I'm showing here. So we wanted to see whether similar modeling, as I talked about before, can perhaps be used to somehow regularize this and make these maps a little less noisy. And again, I'm not going to go through all the physics and math, and of course I don't want to put too many equations into a talk like this. But just to make a long story short, again, you can apply a regularization. Basically, this modeling that I talked about before allows us to create a function that I just call f here that allow us to estimate this and regularize the map. And in this work, we actually made the lambda, the regularization coefficient, change depending on your SNR level. So you would get heavier regularization if your SNR was low. So here you see this in phantoms where it basically doesn't have a huge effect on a high SNR scan, but it has a bigger effect on the low SNR scan. And you get something that looks a little closer to your DWI estimate. Although I should emphasize that those are, as we know, not perfect either. And here are some results from in vivo. And again, you see a bigger effect from a low SNR scan. That maybe looks smoother and looks a little bit closer to your DWI estimate, but hopefully without the distortion. Just moving on to another of these steady state modeling topics. So I talked before about how we can kind of split these spoiling methods into gradient spoiled methods such as FISP or PSIP or DES, or radio frequency spoiled or RF spoiled methods that include flash and SPGR. And again, these are just these very simple schematics that I'm showing on the right here. Now, it can be shown, and again, I'm going to skip over all the math that describes how we got to this, but you can show that a fairly simple relationship between these two signals exists, the S1 and the S2 test signal. It looks a little bit intimidating in the equation at the top, but it can be further simplified into just this very simple thing at the bottom. So it's basically, you have your S1, which is equal to some coefficient times S2 plus some other coefficient. There's a couple of things that are interesting here. So first of all, this coefficient that I call B is actually just what your RF spoiled signal is. So that sort of pops out of the equation. The other interesting thing is that there's no diffusion effects here. The effects of the diffusion or equivalently of your spoiler gradient completely drop out. So what does that mean? Well, there's a kind of a neat geometric interpretation of this. So basically, it means that your signal always has to stay on a line that you can draw in this kind of signal space where you have your S1 signal on the vertical axis and your S2 signal on the horizontal axis. It always has to stay on this line, even or regardless of how big your spoiling and diffusion effects are. So that means that if you start increasing your spoiler, like I'm showing here, it's just going to sort of stay on this line and actually kind of slide down towards the RF spoiled signal. And this is something that is borne out in scans. So here are some phantom scans that I did with several different phantoms, and you get this, pretty crisp linear relationship. And what is this good for? Well, I mean, one thing that you can use it for is that if your measurements are not on this line, for example, if you're doing what I described earlier, where you apply 2 or more scans, one with a big spoiler and one with a small spoiler, they should land on a line like this. If they don't, that's probably because of something like noise. So you can use this as a kind of a low rank prior when constructing your images, so that you kind of penalize any deviation from this line. And I show some phantom results here where we apply this method and get a kind of a smoother map in panels C and E versus the uncorrected one in panels B and D. So yeah, this is kind of a neat relationship. And I'm just going to move on to the next one. This one is a little bit different because it does not involve the steady state modeling that the prior 3 topics have involved. Rather, this involves, well, you can picture, well, like I said in the beginning, like often the endpoint of diseases such as osteoarthritis is that you end up having to need a joint replacement, which obviously is something that we want to avoid, but sometimes that's where you end up. And oftentimes you have to image around these. So these are, this is various devices in the body. I already mentioned joint replacements, but you can also picture like spinal fixations, screws in the knee, and even dental fillings. And these often have to be monitored, especially if there was some kind of major intervention, because you can have problems surrounding these implants later on. The problem, well, there's, first of all, I mean, obviously the biggest concern when it comes to metal and MRI is safety. So you want to make absolutely sure that there's no torque that pulls on the device, and similarly, you want to be sure that that there's no heating involved. But even if your scan is safe, if your device is MR safe, it's still going to affect your image because it's going to distort the B naught field. Yeah, so yeah, these devices are getting more common. So here I'm trying to show this in a schematic here. So say that you want to image some scan volume, and you're just planning to do a bunch of slices, and I've kind of labeled each slice with a color here. So each color represents what's supposed to be just a flat slice. But if there's a metal object in your volume, then these slices don't become flat anymore. They get distorted. And this is actually an actual distortion profile from a sphere, I believe. And so you can spot several artifacts here. So you can see that there's some thinning of slices. There's also some slice thickening as well. There's some slices even see splitting, and you have some slice displacement as well, where they, where you get signal at a different sort of slice location than you wanted to. On top of these, there's also in-plane artifacts as well. And this can result in some pretty ugly and sort of bizarre looking artifacts in your image. This is from a knee scan, and what you're seeing is basically someone having stainless steel screws, and they cause, as you can see, many of the artifacts that I just mentioned. You have slice, you have signal pileup and signal voids and various through plane distortions as well as in plane distortions. Um, so how can we try to fix this? There are methodologies that have been developed to try to lessen these effects, and I'm going to focus on one of them that I've been involved with a little bit, and that one's called CMAC, or slice encoding for metal artifact correction. So the idea there is basically, it's really just, if we look at a representative slice, just like this one here, the idea is really just to treat it as a volume. So you phase encode it like you would do for any volume. Except it doesn't have as many phase encodes as you would normally do. It's often maybe 8 or 16 phase encodes that you do. But the phase encoding allows you to tell what the sort of slice profile is and sort of map it into the actual space. Because if you just going back to our distorted slices, if you don't account for their distortion somehow and just sort of naively reconstruct everything as if you have flat slices, then you get these artifacts that we talked about before. So just what we need is the knowledge of what the slice is shaped like, so that we can map the signal contributions to the right point in three-dimensional space. So so the idea is really just to phase encode each and every slice that we collect. That takes care of the through plane distortions. The in plane displacements can be resolved with what's called a view angle tilting gradient. I'm not going to go into that here, but that's an older method. And then you basically do this for every slice, and so you have a bunch of these volumes that you can then sort of piece together to form your final image. And this works quite well. The only problem is that it takes time because you're adding all this phase encoding. So instead of a quick scan, you have maybe scans that often will take, I don't know, 6 to 8 minutes, something like that. Here you see some results. So this is someone with metal in their spine, and you can see a standard FSE image to the left, again with various artifacts, and to the right you see the image that you get from CMAC. And again, the problem is really just that it takes a lot longer. So what we wanted to do was see if we could speed these scans up. And the approach or the sort of insight that we used was really just that the distortion due to the metal or the metal object itself, if you will, typically only occupies a fairly small part of your field of view. So here you see someone with a hip replacement, the black one on the left. And you can see a sample slice on the right, and you can see it does distort the slice around the region of the implant, but most of the slice is unaffected. So there's a lot of kind of unused space there in this little 3D volume that we've acquired. So can we somehow use all this unused all these unused parts of the volume, basically? So the way we ended up doing that was by using controlled aliasing. So if we go back to this representative slice, instead of collecting K-space fully, like is shown on the bottom right here, what we did was apply a kind of a checkerboard pattern. And this, of course, does induce aliasing, but because of our knowledge of what the slice would typically look like, the aliased copy should not interfere with your actual slice. you don't get this overlap. So that means that it's trivial to just get rid of them afterwards by just masking them out. And once you've done that, you can go on to combine these volumes as you would normally do. So here's some real world examples of this. So here's a schematic to the left and an actual slice on the right. Again, I believe this was from a hip implant. Here you see the results from an undersample scan. And then we've just masked out the copies and could go on to reconstruct as in a sort of normal reconstruction pipeline. And because we're doing this checkerboard pattern, this can reduce your scan time by half. And this also works with other acceleration methods such as partial Fourier or parallel imaging, like I'm showing here. So I'm just gonna go on then. So this concludes the part of the talks that deals with the sort of physics signal modeling. And I'm just going to go on to talk about more computational approaches. And the first one of these is what I call quantitative MRI using neural networks. So as I've hopefully made clear, it is, or we often see it as beneficial to create these quantitative maps of musculoskeletal tissues to hopefully help us make a kind of an objective assessment of the tissue and hopefully at an early stage of disease. And you can do this, of course, you can do it by using dedicated quantitative scans, like a series of spin knuckle scans, for example, for T2 mapping. You can also do it like I've been talking about in this talk, which is to use maybe more advanced methods that are maybe steady state methods that give you both high resolution anatomy as well as a map, and that's more challenging, like I've talked about, because the signal physics are more complicated. But like I showed in these previous projects, that's something that is definitely feasible. But then you can wonder, like, can we just get a T2 map from just your standard sort of run-of-the-mill anatomical scans that are part of a clinical scan protocol? So if a patient is put in a scanner, typically we will run several scans, maybe a couple of different types of FSE or TSE scans, and there might be a desk scan in there as well, but it won't be this. It would typically be the more sort of standard version of it that combines the two echoes, like I mentioned earlier, instead of separating them. And there might be a flash scan there as well. So could you get a T2 map from those scans? I mean, obviously there is the tissue parameters are just the same as they would be for a series of spin echo scans, for example. So the parameters that you want to estimate are the same, but getting from what your image contrast is to the tissue parameter is non-trivial, especially if there's if there's some kind of when one scan is perhaps fat suppressed and another's fat not, and so on. So that's a hard equation to solve. But one thought that we had was, it should be theoretically possible, at least if you have a series of these scans, because you have maybe a number of parameters. You have your T2, you have your diffusion, you have proton density, and so on. So that's maybe 3 or 4 unknowns, if you will. And then you have your equations, one signal equation for each scan. So you have maybe 4 equations and 4 unknowns or something. And the problem is just that the equations are not easy to solve, or not easy to even write down. So how do we get a signal model to go from those scans to the map? And what we wanted to try was, instead of trying to figure out what this model is, just let a neural network figure it out on its own. So the approach we took was to use a generative adversarial network, or GAN. And as many of you probably know, here's a very simple schematic of how that works. You have a generator that produces a data such as an image, and based on some input data. Then you have another network that's called a discriminator that tries to figure out whether that data is real or generated. And the discriminator gets better and better with more and more training at telling whether an image comes from the generator or not. So the generator is forced to also become better, so they compete against one another. And in the end, hopefully, if you're successful, in the end, they've both become quite powerful, and you get images that are realistic. So the way we did this is shown here. So we took data from what's called the Osteoarthritis Initiative. That's a public database of knee images. And in that project, they collected a series of these anatomic scans, as well as a multi-echo spin-echo scan to do T2 mapping. So using that, we could have this sort of ground truth to create a T2 map. But the training of the network would basically, the network would create the T2 map based on, not on the multi-echo spin-echo scan, but on the other anatomical scans instead. But the spin-echo measurement served as a kind of a ground truth to see how well we're doing. And I'll also point your attention to the part on the right, where there was another little network that we used to generate a mask that covered the cartilage. So so after having standardized the field of view and scan plane and so on, so that the T2 map and all the different anatomic scans had the same field of view and scan plane. We also had this mask that allowed us to kind of focus more on the cartilage, if you will. So that resulted in this network design that I'm showing here. It may look a little bit intimidating at first, but the key thing to see is basically just that there are two discriminators. That is to say, there are two pink boxes. So one of them focuses on looking at whether the whole image looks realistic or not, while the other one looks at the whether the image or the T2 map rather of the cartilage is realistic. So that way we were kind of able to sort of focus the processing on the cartilage, but not entirely. The whole image had to look pretty good as well. So this was trained on 3,000 subjects from the Osteoarthritis Initiative, or from the OAI. And the validation set contained about 460 subjects, and a test set as well. And here's some sample results at the bottom. And you can see that they match quite well. And we also, on top of this 456 subject test data set, we took a smaller sort of sub-test data set of 30 subjects that we had two radiologists examine to see how well, well, first of all, we had them look at whether they could tell which of these maps was real and which one was not. So that was one part of the analysis to see if you could, if you will, kind of fool the radiologist. And once that analysis was done, we had them also assess how the synthetic quantitative map compared to the real map in terms of things such as SNR and sharpness and artifacts and so on. And it ended up performing quite well, I think. And even on top of that, it turned out to sometimes actually resolve artifacts that you would get in your standard spin-echo scan. So here on the to the left of that row of images at the bottom, you see a multi-echo spin-echo T2 map, and you see these sort of red streaking artifacts at the bottom, and these are pulsation artifacts from the popliteal artery that show up as these, as these kind of streaks that are not real, and you actually get rid of those in your neural network map because the input data does not suffer from those artifacts. We did also on that smaller subset of patients, the 30 patients that the radiologists looked at, we did a more sort of thorough quantitative analysis as well, where we segmented the cartilage into these 6 regions, deep interior, superficial interior, deep central, and so on, and did just to get on top of the radiologist assessment, to get a kind of an objective, a quantitative assessment as well, just to see how well the numbers matched. And we felt like they matched quite well, as you can see. And it's maybe okay to have in mind that different T2 methods, 100% agreement between 2 methodologies is not really what you should be aiming for necessarily, because they all have pros and cons. So getting something that agrees pretty well and it can be useful, especially if you're doing like a big study where you're using the same methodology for all the subjects. Then you can detect whether certain subjects have higher values than others, and so on, and whether you see any differences longitudinally and so forth. And here, just to show a few more results, here you see this matrix of images on the left. These are basically, each column represents a patient. One of them is not as the OA condition is not as bad on that one. Then you have a somewhat worse one in the middle, and then the column on the right has a pretty far kind of regressed cartilage. And I'm just showing this to show that our method seemed to perform well in all these cases. We also did an analysis of oops, sorry about that. Sorry about that. We also did an analysis of when the network was successful in kind of fooling the radiologist, if you will, whether those cases had anything in particular in common, such as is the network better at producing realistic T2 maps for patients of a certain age, or patients that are more sick than others and stuff like that. But we weren't really able to detect anything statistically significant. So it essentially seemed to perform similarly for all these groups. So that's all I have for that project. And then the last topic I'm going to talk about is a little bit different, maybe a little bit sort of outside the box, if you will. It has to do with augmented reality. And this is a project that was born out of the sort of low field considerations that, or the low field research that is done at the Martinos Center. So, if I draw this matrix here that has just a conventional MRI acquisition on the top left, then there's been a lot of research at the Martinos Center by our group and Larry Wald's group and several people on whether you could get more portable, low cost alternatives to this. And if you then put in the top right just how these images are analyzed, typically in a reading room where a radiologist sits and analyzes these pictures using special software and so on. What I wanted to look at was whether you could fill out that quadrant in the bottom right. So could you get some portable low-cost alternative to analyzing the pictures or the images once you've acquired them? And that way you could get this sort of that could complement the portable low-cost hardware approaches as well. So what I ended up doing was looking at whether we could use smartphone technology for this, and this way make the visualization easier and more intuitive. And essentially what we did was create this augmented reality software that basically the anatomy is kind of hovering, so that the idea is that it's kind of like you're looking into the body as you move your phone around, so you can look at it from different distances and different angles. And we had a number of people, 15 people, test this to see how easy it was to use compared to more conventional approaches. And we also had an analysis done of how good this was for detecting pathology. So we put some synthetic lesions in a data set such as the one you see in the video, and we asked people to basically find them, and we saw when we timed how long it took. And as you can see here, using several metrics for sort of ease of use, people found on the whole that the augmented reality approach was in a lot of ways more intuitive. They were quicker to learn how to do it. And they were also able to find the pathology faster. Yeah, that's the last topic that I had. We've used these methodologies that I've described in some other situations as well. We're actually expanding this signal modeling that I talked about in the beginning into other tissues such as muscle and peripheral nerves at high fields. That is really interesting and is sort of a project that is ongoing. And there's been a couple of other projects as well that are ongoing, and I look forward to showing in future presentations. With that, I would just like to thank my advisors and collaborators and my funding sources, and I just thank you as well for your attention, and I welcome any questions you may have. Thank you.
Thank you so much, Dr. Sveinsson, for this great talk. And as you said, we now move to the Q&A phase. And I'll just remind the audience to please address your question either using the Q&A box, the chat, or just raise your virtual hand. And while people are typing, I'll enjoy the benefit of asking my questions. So for the augmented reality, I'm just curious, can you project it on any leg? Like, you don't really need the subject's leg, right, to examine the pathology, or do you?
No, yeah, it's I mean, ideally in the future, it would be, it would be nice if it somehow, sort of checked that you were, looking at the anatomy that belonged to the actual person that's in your image. But right now it doesn't really do anything like that. You just choose a data set from a menu and sort of project it onto the leg or whatever anatomy that it is that you're looking at.
Cool, very cool. And another question, and you demonstrated the very nice application with the GAN to basically to get the T2 maps data. Can you use the same approach to correct for the Mertel artifacts or to remove them? You think?
Oh, that's a great question. Yeah, I would think so. I haven't really thought about it much. I mean, I did show like that we got rid of those artifacts from the artery, so you could picture that something similar could possibly happen. So you could maybe train the image, train your network on images where you have some kind of ground truth that is maybe observed, that is maybe collected using perhaps something that is not sensitive to metal artifacts, maybe a purely face encoded scan or something like that, or a low field scan, what have you. And then you could use that to get rid of artifacts and more sort of standard anatomical scans. I think that's a great point, actually.
Cool. And another question I have is, you mentioned the use of the models. Although they're complicated for the study set, do you think the incorporation of the actual physical models in the GAN somehow, or generally in the neural net, could assist in improving their performance or contribute in any way, or should we just look at the neural network as the representative of the underlying phenomena?
Yeah, no, that's a great point. Also, it's something that I thought about a little bit when I was doing that project, whether we could, get a better kind of error metric by comparing it not only to this, T2 ground truth that we had, but also maybe have some kind of physical model that you could test it or sort of check it against as well to get maybe a more sort of efficient penalty function. Yeah, so I mean, just sort of, I ended up not putting that in there, but sort of intuitively, you would think that it should not at least hurt to have added information of the signal physics in there as well.
Got it. Thanks. And maybe one last question. You mentioned taking the images for the artifact removal project. You mentioned that you were combining images with different orientations and resolutions and correcting for the field of view. Can you give some more details on how did you register them?
Oh yeah, it's basically, it's all just from the DICOM header. I mean, the DICOM header contains the patient orientation and scan plane and so on. So you can actually, it's a little bit laborious, but you can figure out the physical location of each voxel, so that way you can sort of resample it onto a new grid so that you get the same so that they're all sort of equivalently localized in space.
Got it. Yeah, I thought it was somehow related to the network that detected the cartilage region, but it was something separated.
Yeah. So that initial pre-processing, where they all were co-registered, that was just purely computational based on the DICOM info, and then that got fed into them.
Got it. Great. So I would like to thank you once more for this great talk. And thank you everyone for joining. See you next week.
Thank you.